Okay, let's talk about this cool case of a pulmonary embolism. This was a 31-year-old female who presented to the emergency department with acute shortness of breath and a sensation of her heart racing. This started right after she left the ortho clinic where she was getting care for a knee injury and a presumed ACL tear. A couple of weeks earlier, she has been in a brace. And then suddenly, as she was leaving, she became short of breath. She felt lightheaded, nauseous, and vomited. She endorsed a swelling in her knee, which has been persistent and consistent with the presumed ACL injury, but now her calf is swollen as well. She has no chest pain, no fever, no cough. There's no past medical or surgical history. She is on oral contraception, and she occasionally smokes and occasionally drinks. On exam, she is afebrile. Her heart rate is 121. Her blood pressure is 145 over 53. Note that pulse pressure. Her respiratory rate is 23, and her oxygen saturation is 92% on room air. She looks diaphoretic and anxious. Her HEENT is normal. Her heart sounds, she's tachycardic, otherwise normal. Her lungs are clear. Her abdomen is normal. And her right lower extremity, she's taken out of the brace. She has an obvious joint effusion, which is noted right here. This is, of course, not our patient, but you can see a large joint effusion on the knee here on the right. Shin and calf swelling is also noted with tenderness below the patella, a positive anterior drawer test, no popliteal mass, and normal vascular exam. In the ED, she is placed on a monitor, placed on oxygen, and IV access is obtained. She has an EKG shown here on the right, which shows sinus tachycardia. Without counting these out, you can see this is very fast. She has T-wave inversions in the in the precordial leads, V1, 2, 3, and 4, as well as lead 3 here and lead AVF. Okay. Her chest x-ray is normal. Her troponin is elevated. Her leukocytosis is 16,000. Her glucose is elevated at 193. Note that she is not a diabetic and has not been on steroids recently. Otherwise, her labs are normal. Her pregnancy test is okay. In the emergency department, she suddenly becomes more ill appearing. She's now reporting chest pain. She's more tachypnic. She's now hypoxic even on the nasal cannula, which is converted to a non rebreather. And she becomes hypotensive despite a liter fluids of normal saline. So let's talk about pulmonary embolism. Okay, there's about 600,000 cases in the United States annually, and 1 to 200,000 die. So that mortality rate can approach 1 in 3 patients, and that mortality essentially correlates with how hemodynamically unstable they are. They generally originate from a deep vein thrombosis in the legs, and remember Virchow's triad of venous stasis, hypercoagulability, and vessel wall inflammation. Risk factors include prior DVT, recent surgery, mobilization, thrombophilia, age, malignancy, CHF, contraception use, hormone therapy, and prolonged travel. You should think of pulmonary embolism like many other diseases. It's really a spectrum. There's a lot of people walking around with clinically insignificant PEs, and then there's some folks who develop massive fatal PEs, okay? Signs and symptoms. Symptoms can be kind of vague, but chest pain, dyspnea, back pain, shoulder pain, hemoptysis, vague thoracic discomfort, and anxiety are common. The classic triad in the books of hemoptysis, dyspnea, and chest pain is very uncommon, and almost a third of patients deny chest pain completely. They're often some form of tachypnic, tachycardic, hypoxic, or hypotensive. They can all occur. If they're really sick, they may have signs of either congestive heart failure, which would be rales, lower extremity edema, murmur, and neck vein distension. They can also develop fevers. And on the right here, you see a table of signs and symptoms that sort of reflect the findings in pulmonary embolism. EKG, chest x-ray, and blood gas are tests you're going to obtain because they screen for other pathology, but for diagnosing pulmonary embolism, they're not extraordinarily useful. Typically with EKG of sinus tachycardia, less commonly T-wave inversions in the precordial leads, famously S1Q3 T3, but that is not commonly seen. Right bundle branch block and AFib can also be seen. Chest x-ray is not specific, but again, rules out other conditions. Here you can see Hampton's hump right here, which is a sign of a massive PE, and then Westermarck sign, which is a sign of pulmonary infarct. D-dimer is very sensitive, but it's not specific, meaning a lot of other disease states can cause an elevated D-dimer. But it's good to rule out PE in low-risk patients when combined with other decision-making rules like Perk and Wells. And then, of course, if the dimer is elevated, you got to do more. Ultrasound is useful to identify the source of the venous thromboembolism. CTA or CT angiography of the pulmonary vessels is the gold standard. Sensitive, specific, and can be rapidly obtained. And VQ scan is reserved for select cases in patients who have a contrast allergy, for example. Treatment, initially an echocardiogram is obtained early on in care to assess how severe the right heart strain is. And you can monitor therapy response as well. The treatment initially is going to be either an oral anticoagulant or heparin or low molecular weight heparin. If they're really sick, though, right, they're unstable, they need more, you have options. Catheter-directed thrombolysis is common. Thrombolytics are common. Embolectomy, much less common. And if this is a healthy patient, ECMO is a good choice to bridge them until you can get the clot burden out of the heart. In the case of our patient, she was diagnosed with bilateral pulmonary emboli. She was started on enoxaparin in the ED, IV fluid, and then eventually levofed because the fluid wasn't cutting it. Thrombolytics were administered in the ED. Patient subsequently had normalization of her vital signs, and she was weaned off the levofed drip fairly quickly, but still went to the MICU. She had a repeat EKG here, which is now normal. Notice that the T-wave inversions have mostly resolved. 3 AVF, these are all essentially normal. She also had a bedside echo, and this is a very classic finding of right heart strain. So this is the left ventricle, which should be much larger than the right ventricle. This is the right ventricle, which is clearly much larger, and it has been measured out here to be larger than the LV. This is right heart strain. Doesn't mean that they have a PE. In this case, she does, but you can have right heart strain for other reasons. Ultrasound showed an occlusive thrombus in the right superficial femoral vein. And here are 3 key points for pulmonary embolism. The first is that the classic triad of hemoptysis, dyspnea, and chest pain are unreliable, and up to a third of patients have no chest pain at all, which can make diagnosing PE very challenging. D-dimer testing combined with Wells and PE rule-out criteria can help rule out PE in low-risk patients, and then CTA is the primary diagnostic tool in moderate or high-risk patients. Treatment depends on stability. Stable patients receive anticoagulation, whereas unstable patients with a major or massive PE require some form of thrombolytic therapy and admission to the ICU.